Hi, everybody. This is Jenny. I'm the sleep airway specialist here with Great Lakes. We're super excited to have Dr. Thornton here with us today. Dr. Thornton has been a great partner, but more so a fantastic friend of Great Lakes for decades, and we're very, very happy and excited to have him here with us today. Any questions that you may have, if they're not addressed during the webinar, we will reach out afterwards and make sure that everything's caught up on. We'll make sure everything's addressed for you. So if there's no more ado, give us just a second. We're in two different locations, so we're going to take this over to Dr. Thornton and let him have the show. We'll take just 1 second. Thank you.
Great.
All right, I'd like to welcome everybody to this webinar. I'm not real skilled at this, and so this kind of some of my first time, but really am excited working, and always have been excited working with Great Lakes for over 30 years. They're delightful people of great character and do a great job, so it's been a real fun time. So we get started. The advent of the flexTAP, and we call it a new appliance for better restorative sleep. What I would say is that it is really a new classification of an oral appliance, because what we are doing is, and we'll go through that. We'll submit any questions, like we said, at the end. But our agenda is why tongue space is critical for an oral appliance, how breathing through the nose improves the treatment outcome, how the flexTAP can benefit both you and your patients, and the importance of the new AM liner. So what we're talking about is what we need to do is look at treating the nose and the tongue. We got to breathe through our nose, and we got to get the tongue out of the airway. And those are the two most important things that we can do. If you look at all the rest of the appliances, they're all 50 to 100 years old orthodontic appliances that put the upper and lower jaw together and move it forward. So what we're looking at is saying we're really treating the pathophysiology of the airway by redesigning the device that we have. So let's look at the overview. Obviously, it's a custom. It meets EO4H6. There's no metal parts in it. The Vertex technology is utilizing the anatomy and the joint and the way the joint moves to open the airway to bring the tongue forward. So as we move the jaw forward, we move it down, and we will show why we do that. The mouth shield comes with all of that. It is critical, as we now know, and a lot of people are into how the breathing is that we need to breathe through our nose. And so what we're treating with this is not only the anatomical issue, which all other appliances treat and CPAP treat, but also we're looking at the control of breathing through the chemical control, central chemical control. So we're addressing all the phenotypes. No other appliance does it. That's why I call this a physiologic, nighttime physiologic breathing device, and not just a mandibular advancement device. We not only advance it, we open it up for room for the tongue. We do have some new irradiated thermocryl liner. This is all thermocryl with a little bit of plastic in it, but there's no metal parts. So if we go look at how we breathe, and we take a look at that, and it goes back to our dental school days, that we always have freeway space, room for our tongue. We do not breathe with our teeth together, but we have an average of what we call freeway space, which is about 3 millimeters. And we bring our tongue down and forward, and our jaw down and forward to get the tongue out of the airway to breathe normally. The back of the tongue is the forward part of the airway. So if you look at all the academics and the studies showing that that's the critical part. It's not the jaw moving forward, but it is the tongue moving forward. So this is a patient, he actually is a marathon runner, but was fatigued, snores, and had some issues, and does have sleep apnea. So you look at, took a picture of him, and you look at his mouth, and he is a mouth breather, but look at the position of his tongue. It's down and forward and in between his teeth. So one of the very quickest things as far as evaluating and diagnosing a patient is take a look at the size of his arch, very narrow. Look at the indentions, obviously a scalloped tongue. It's almost like he's taken an impression of his upper arch with his tongue, so that you see this part goes into his palate, but this part goes in between his teeth. And so we looked in and saw that he had a 10 millimeter vertical opening or freeway space. So he's got, as we say, a big fat tongue and needs more room for his tongue if we're going to treat him with appliance. So this is the physiology and the mechanics of the TAP appliance. We are considering, and you can consider that we're creating a bigger box. Open this up, nothing in between the teeth, allowing the tongue to come forward and to the side. A tongue is a hydrostat, which is essentially a balloon, a water-filled balloon, and so it maintains the same volume. And so as you move the tongue forward, it gets thinner, and there's more room to get it out of the airway. The real key to this is moving the jaw forward and down, and this is why the post is angled at 45 degrees, and so that as the jaw moves forward and you titrate it forward, the lower jaw moves down and forward at a 45 degree angle. So what is vertex technology? This goes back to Watanabe and the anatomical imbalance. So we're going to talk about the anatomy first, and then we'll talk about the airway and breathing through the nose. But a normal airway, you have a normal sized tongue, soft tissue, normal sized bony enclosure, our oral cavity, and therefore a normal size open airway. An airway really is a very flexible, collapsible tissue surrounded by muscle. So that it's not connected to the bone, but it just is a muscle. So the muscles keep the airway open. If you got a big fat tongue, obesity, and a normal bony enclosure, you reduce the size of the airway. If you have a small bony enclosure with a normal sized tongue, again, you have a restricted airway, and this is what I call the skinny women's disease, or our high upper airway resistance. This was a study done by Schwab. As you can see, our tongue is a fairly big piece of meat, as I call it. This is the posterior part of the anterior part of the airway, and so our tongue is very large. So as we move it forward, we need more room for the tongue to move out of the airway. So as I say, we got boxes for our tongue. This is the oral cavity. This is the way our tongue is. When we open it and move it forward, we have much more room in the box for our tongue. Vertex technology. Most appliances are built with a 2 to 5 millimeter vertical. They advertise it, oh, we got a small vertical. The problem with that is not physiologic, and they put plastic in between the teeth and it blocks the ability to and makes the box smaller. Obviously, it limits room for the tongue and forces the tongue backwards, doesn't allow it to come forward. With the trays tethered outside the mouth, and this is really key, is that there's no way that lower jaw can rotate back and allow that tongue to fall back. So anytime there's movement with the tethered out there, the jaw is actually moving forward, and I could show the mechanics of that. Also, as I said, lets them move tongue forward and out of the airway. So you get a bigger box like that and more room for the tongue. So we go back to what I think is the best study, really evaluating, I think it's over 40 trials, randomized controlled trials. And although they didn't identify which appliances they were studying, I went back and analyzed that. And we took a look at it and say, okay, can we compare the appliances and the outcome? And this was generally against CPAP. So this is the first discussion of the technology of how we move the jaw forward. We got bilateral thrust versus midline traction. The TAP is really the only one with midline traction. Bilateral thrust, you've got a number of these. We had 20 randomized trials that looked at the bilateral thrust and the midline traction. So as you can see, midline traction, you're pushing, midline traction as you pulling forward. So here is one of the critical things about this. In fact, there was a new study just out published very recently talking about that this type of device, Somnodent or Hertz, has a pushing ability, but the problem is that rotation is allowed. So if you open the jaw will go back and it doesn't work anymore. So in 50% of this group, it didn't work. So versus rotation versus the TAP, there's absolutely no rotation because the lower appliance is attached out here. So any movement down actually will translate the condyle down and forward. So these are pictures of Somnodent, and I say they put either Somnodent or most appliances put plastic in between the teeth, and as you notice, this is a rubber band and the thing is locked together. So if you want these to work, you actually have to lock them together. And essentially with 4 millimeters, there's no room for the tongue. In the study that Huckelman did, and most of the 7 randomized controlled trials, he had a 12 millimeter vertical, and therefore if you have 2 millimeters on the occlusal surface here, 2 millimeters on the occlusal surface here, you got 6 to 8 millimeters of vertical space for the tongue to come forward. So let's look at the actual outcome. We added both the Somnomed and Hertz and averaged them. The Somnomed Hertz is a push, the TAP is a pull. AHI before on this group was 21 or moderate. Actually, the BMI was under 30 in the TAP. It was average almost 40. They were severe, they were older, and the BMI averaged over 30. So in this group, the AHI after was down to 12. So it reduced it 9 AHI, which is only 42%. So on the TAP, it was 7.8 reduction. So it reduced it by 31, which is 77%. So the protrusion in all the Somnomeds, not necessarily the Hertz, are protruded to maximum comfortable protrusion. Most people don't know that. And TAP was at 89. And the outcomes is you have to get greater than 50% reduction to below 10, and both the Somnomed and Herbst didn't reach those. So the critical issue is that when we protrude the lower jaw forward, the whole jaw is actually moving down because you have translation of the condyles. And we know that because we can have teeth on posterior, cuts on posterior teeth with a flat anterior guidance. So with horizontal movement of the lower jaw, you actually get vertical movement of the condyle and most of the mandible. So this is the mechanics of the TAP appliance. We have 10 millimeters. If we move the jaw 10 millimeters forward, the jaw joint goes down 10 millimeters and down the eminence, and we know that's translation. We do the same thing with the TAP with our Vertex technology, move it parallel to the condyle, and what happens is we have room for the tongue, and the upper and lower jaw is parallel, so our path and plane of occlusion is parallel, and so we have room for the tongue in between the upper and lower appliances. And there is no rotation. So when we say, oh, there's when you open the jaw, you're rotating back. That's not true. It is not rotating back. It's actually maintaining a space between there, and the jaw joint goes back. If you rotate around here with this being held out there, you actually, the only way to close or open it out at this point is to translate. So there is absolutely no rotation back with the TAP appliance. I want you to do this exercise with me, and it's kind of a fun thing to feel what your tongue does. Keep the tongue in the roof of your mouth and put your teeth together and move your lower jaw forward. So it's very difficult, and to keep that tongue in the roof of the mouth with your teeth together. Now open your jaw and with your teeth apart, and move your jaw forward with and allowing the tongue to come between the teeth. And you can see that allowing the tongue space, the tongue comes more easily forward, and therefore flexTAP requires less protrusion. That's one of the things I've seen over about the 4 years that we've been using it, that we do not have to move the tongue nearly as far forward. It's more comfortable. Actually, the jaw can move in 6 degrees of freedom, left and right, forward and back, and up and down. So, second part is, how does breathing through your nose improve treatment outcomes? And one of the things that people have either noticed, complained about, or questions is the post sticking in between the teeth. And as somebody said, well, it's better than having the CPAP on, but it really makes the whole thing work better. So it's just getting beyond the thought process of having this post out there. But once they start using it and see the mouth shield and feel that, then you get beyond thinking about the post. So the perks of the nasal breathing: produces nitric oxide in our paranasal sinuses. We breathe nitric oxide. This acts as a filter also for reducing risk of infection, moistens the airway, improves oxygen circulation, and results in a deeper and restorative sleep. So how does the mouth shield work? Because we open between the teeth, you've got to prevent breathing through the mouth. And so the mouth shield forces you essentially to breathe through your nose. So this is a friend of mine who I've been treating for over 10 years, failed CPAP. He's 69, 228, almost obese. His baseline HI was 45. So he was a severe sleep apneic and had all the symptoms. So I've had him in a TAP for that long, and he's gone through about 3 or 4 different styles of it. And so the last one was a Dream TAP. And so this is a comparison in the Dream TAP without a mouth shield and Dream TAP with a mouth shield. And as you can see with the Dream TAP, it had a 29 HI. With a flexTAP, it had 10. And the real issue is the only difference between this is the mouth shield. And as you can see, this is his oxygen saturation. During the first of the night, he had fairly severe sleep apnea, and it calmed down, but you can see the sawtooth shape of the oxygen saturation. With the mouth shield, his baseline oxygen saturation was 94%, whereas without anything it was 90, and Dream TAP is 93. So one of the things I look at is saying, is he having any significant desats? And he really is not. Whatever desaturation he has is very minor. This is one of the things that I really focus on and take a look at it. And one of the things I do when and I've been doing this for over 30 years, is looking to just oximetry and the changes in the printout on this. And as I say, more ink on the page, less ink on the page. As you can see, the heart rate average starting out without any appliance was 78, dropped to 72, and with the flexTAP went to 64. And as you can see, and I tell patients to show this, is that less ink on the page down here, and it's calming your heart down. His blood pressure at baseline was 150 over 89. Put him on meds with Dream TAP was 135 over 85, and then it still dropped it down with flexTAP, even though he's on medication. My next patient was in about 3 or 4 days ago. Female, age 60, weight 262 now, 65. So she had a BMI of 45, very obese, baseline of 64, baseline blood pressure was 160 over 89.
Okay, can you tell me your name and which appliance you're using?
Bettina Ernst and the flexTAP.
And how is the flexTAP working for you?
It's working great. I cannot sleep at all. And on it.
Great, and were you being treated with an appliance before flexTAP?
Yes.
Which
But
one?
I don't know it.
I think it's the Dream TAP. Yes.
The Dream TAP, which was also great, but this one's better. It's more flexible. It feels less tight and hard in my mouth. It's just working really well.
And are you using the mouth shield?
I am, which I could not do with the Dream TAP. But this one, and it helps so much, because when I wasn't using it, I was tending to breathe through my mouth a little bit. And now this thing helps with me not waking up to dry throat and scratchiness and stuff.
Any other comments about the flexTAP?
I am very, very thankful for it. And I know that's the only reason why I'm getting good sleep for real. And I'm just thankful to be having it.
Great, thank you.
Okay, let's take a look at her pulse oximetry. As her baseline was 67. I don't have a picture of that, but this is the upper one is with a Dream TAP. As you can see, she still has severe sleep apnea and lots of desaturation. Her baseline was 91%. With the DreamTap is 92%. And with the flexTAP, it was 94%. As you can see, it really calmed her heart down. And this was, looked very, this was probably in REM sleep where you do desaturate, but the rest of the night was was excellent. So let's look at her heart rate. That really is significant. When you see the acceleration, deceleration of that, you know there's a lot of sympathetic response in here. She was fatigued, more fatigued. She still had high blood pressure. And again, baseline was 78. With DreamTap, it was 72. And flexTAP went down to 64. As you can see, as we say, during the night, she became, was still having a lot of apneic episodes. This calmed it down. And what I like to see is this dipping effect. She started out at about 70, and over the period of night, she went down to in the 60 and below 60. So as you can see, her average was significant. This is what was really significant. She started out baseline at 140/85, and this was about 10 years ago. With the DreamTap, it dropped it down, but she was still on meds. With the flexTAP, she's gone off meds and is doing very well. So that's pretty significant. So what does nasal breathing do? It recalls it the central chemical control feedback loop. One of the things is what controls our airway. It's not only the position of the tongue, but also the position of the jaw. And there's some new information that our jaw closing muscles and muscles are part of the airway dilating muscles. So all of this is controlled by the chemical control, CO2 and O2. So we've got nasal breathing, and I'll talk about nasal breathing because that's physiologic breathing. Oral breathing is an emergency, and we have real issues with blowing off CO2 and having issues with the control of the breathing. So we have the arterial CO2 and O2, oops, I gotta get help from my show your head, Kelly.
Hey, everybody.
I'm digitally challenged, trust me. I got this millennial that knows what she's doing. Yes, that's good, thank you. So arterial CO2, find this, it's not moving forward, Kelly. All right. You got your chemoreceptors, carotid bodies, in the central and the brain. The quick ones are the chemoreceptors in the carotid body. We have the respiratory control, have controls the muscles, diaphragm, airway dilator muscles, including the muscles that controlled by the trigeminal nerve. There's some good studies. There's a new testing device called the Sunrise that measures that. It really shows how our muscles mastication is an airway dilating muscle. And then we have breathing, tidal volume, and then we have nasal breathing. So that's the central chemical control. That's what everybody is looking at as these phenotypes that they're treating. So what is physiologic breathing and nasal breathing? So what does it do? It maintains the CO2 levels, respiratory drive, reduces sympathetic tone, increases airway dilator muscle tone. This is really an important thing. And all of this, and most of this was reported by Guilleminault many, many years ago, talking about the chemical control of the airway. This increases the CO2, maintaining CO2, improves the uptake of O2. It's a Bohr effect. Obviously, it humidifies, filters the air. We have uptake of nitric oxide as a significant vasodilator. I think this is one of the things that is so important about why we need to breathe through our nose. It reduces blood pressure, opens up the arteries. It also kills viruses and bacteria. There's a study showing that nitric oxide does this, and we're seeing some, just anecdotally asking patients, can you breathe through your nose easier? Have you had as many colds or whatever in the last couple of years? And we've seen some improvement. A lot of this information, we need to have good randomized controlled trials, which we are starting to do at our A&M Dental School. We have a preliminary study that it improves neurocognitive outcomes by wearing the mouth shield. Preliminary indication of treating AFib, we've got a study going on that, and treatment of periodic breathing, which is more of loop gain and issues with that. So we're looking at treating all of the three phenotypes that Danny Eckert has been discussing and with the mouth shield. Kelly, I can't make it go forward. Okay. So what we have, all phenotypes, everybody that has sleep apnea essentially has a small collapsible airway, or the anatomy are obese, and the anatomy is the real issue in virtually all of patients. The therapy for this, either CPAP or oral appliance, is always mechanical, and the flexTAP. However, when you start to get the various phenotypes, and there are three of them, there's low pharyngeal dilator muscle control when it's asleep, upper airway response, and with nasal airway and CO2, that it improves the response of the airway muscles. This is a study that Gimeno did, and this is what's happened with the flexTAP. Low arousal threshold, we talk about the skinny women's disease, young female, breathing through the mouth, narrow arches, narrow palate, and they're very hyperarousable. This is what low arousal threshold. Well, it's like, how do you calm somebody down that's having a panic attack? You have them breathe in the bag. Well, this is increasing the CO2. Once they have the mouth shield on, CO2 goes up, and they are more relaxed and breathing easier. And that's the same thing that all we know about breathing through the nose during the daytime. It occurs at the nighttime. The loop gain, again, is increasing the CO2 level and maintaining respiratory drive by increasing the CO2 level. And this is very well known. And there's a couple of people that were trying to develop machines to do this for CPAP. CPAP doesn't do that, and they were trying to add CO2. We've done it with the TAP-PAP with increasing the dead space by increasing the length of the tube, and have treated this complex sleep apnea that's both central and obstructive, and have had a number of success. Again, we're looking at doing some studies on that. So we have the phenotype: small collapsible airways, mechanical, and we use the flexTAP. Again, low pharyngeal dilator muscle activity, nasal airway, flexTAP with mouth shield, low arousal threshold, nasal airway, CO2, flexTAP with mouth shield, loop gain, nasal airway, CO2, flexTAP with mouth shield. And if that doesn't work, we go to the TAP-PAP, which seals better, absolutely no leakage, which is very important with maintaining the CO2, and increase the dead space so that we have great improvement. This was a study published by a physician at Harvard that looked at this and published on this. So how flexTAP can benefit both you and your patients. This is a real issue. We're looking at not only, the ability of devices to maintain normal breathing and normal CO2, but you ought to have that it's easy for not only the patient, but for the dentist to do, and we call it practice management. So features of TAP versus other appliance, patient control protrusion. This is in the mouth, and we've seen this over 30 years, that with it in the mouth and the patient can adjust it with the knob on the front, then the patient can adjust it anytime they want to. So over a period of years, a year, 2 years, 3 years, we see patients dialing it out so that it continues to manage the airways. So you might make a device with say at day one, that works for that patient, but that patient can gain weight, they lose weight, they can actually change it night to night, drink a couple of glasses of wine. They may need to turn it out 2 times, or their wife may need it to turn it out if they're asleep and it's disturbing the wife. This changes the size of the box as we move it out. No other appliance can do that. You can titrate it easily. Patients can titrate it easily. They can do it at home and with multiple titrations. It is universal. It can treat all severity patients, even severe, as Huckema said. And biggest issue, and I think differentiates us from anything else, is promotes nasal breathing. So delivery time, it is easily adjusted, either if it's a little loose, you can, or a little tight, you can heat up, vary it within 10 seconds, put it back in the mouth, and improve the fit. There are no metal parts, or changing out hooks, or trying to adjust the forward position by turning a screw on either side, and you don't know which side to change. And as I say, you can do a hook or a slice with this and not do the same way, and it's easily adjusted in the mouth. It right now has a 14 millimeter adjustment, and it will be 17 millimeters soon. It can adjust it in 1/3 of a millimeter adjustments. We've seen that, or half or 2/3 of a millimeter, change it significantly, and does it. The real critical issue is it doesn't require bite. Is that, as I always say, if somebody is obstructed and needs CPR, you don't go down, oh, I can move that patient's jaws 5 millimeters forward and open. No, you open it up, move it forward far enough until they can breathe. And this is why it's so easy. We can start patients out at a minimal protrusion, and then have the patient titrate themselves out to where they have a successful, and their symptoms are gone. And that can be done over a period of time. So we're not putting that person in their treatment position in day one. It's the lowest cost appliance that we have at our company. And you can compare it to the price of any other device, and with the benefits it has, that certainly it is a very good value for your money. It is also covered under Medicare under EO 486. All of our appliances are that, and that we have a 3-year warranty. So here are some of the feedback. Dr. Luisi has been doing TAPs for probably 30 years. As he said, finds it more comfortable, increased range of motion, allows significantly more room for the tongue. And obviously that's an important thing and improves efficacy of the treatment. One of the nice things, and people ask about TMD, whatever, with this device and the way it's made, the patient can move their jaw so they don't feel locked in, move it to what we call 6 degrees of freedom, right and left, front, upper and lower, and they can move it forward, but they can't move it back. So it continues to lubricate their jaw. If they want to bite down on it and swallow, this technology will allow them to swallow. They hit in the back and can clench in there, but it tends to have some ways that it pulls the upper and lower jaw apart and keeps it at that 10 millimeters or 8 millimeters opening. So we see people that we don't have to move the jaw forward, and it's easier for them to get their teeth back together in the morning. Dr. Cardosi said the mouse gel is slightly edged the bulk of the appliance, so effective that I wouldn't use the appliance without it. Comfort is great and improve his quality of sleep. So that's a dentist that's wearing it. I do go to Appliance for his practice. I think this is one of my best inventions, and some people have criticized it because it's too thin and light. I designed it specifically for getting people's occlusions back to maximum intercuspation. When they bite down on it, and this is cleared, that's only 10 to 20 microns thick. So we know that patient is back into maximum intercuspation and back to where their teeth started. It's very simple. We hand it to the patient. Once we barely clear it, they bite down on it and they have a handle to put it on. So we actually sell it to a lot of other laboratories to put with other appliances, and I feel very good about that device. So if you want to contact Great Lakes, call Jennifer. She knows everything. And as I always say, I think about half of this is what I've said is correct, and I don't know which half. So anyway, thank you. And I'm going to turn this over to Jennifer, I think. And this is a time for question and answer.
Hey, everybody. My name is Kelly. I've kind of been sitting in the background. But we're going to start answering some of the questions y'all have submitted in the chat. And so we have a few questions. I'll go ahead and get started. I'll say the question out loud, have Dr. T answer it. First question, someone was asking about the getting citations for some of the papers you cited, which I think we could send out after this webinar for everything you talked about. And so then the next question, let's see. Do you have any muscle exercises for muscle adaptation, and what is your titration protocol?
Typically, we don't, I don't discuss that with patients because we don't see a lot of it with this device. And anything that you want to do that, you know, NSAIDs, having them work with the jaw, I just haven't done it in my career that I've needed to do that very much. What was the other?
What is the titration protocol?
Titration, that's a good question. What we do is have the patient turn it about one turn every night for until they are, and I'm saying a half a turn every night until their symptoms are reduced. I then ask them to go ahead and turn it out 4 times more than that. I measure them at that point and then to maximum comfortable protrusion, and then have them measured at that point. So this is over a period of time. Most people's symptoms go away about 2 millimeters before their AHI is lowered to below 5. And that study has been done a number of times on the TAP appliance, and we've got that information in those studies.
Great.
Dr. Thornton, this is Brian from Great Lakes. I'm going to jump in because I'm seeing some of these questions come in as well. The next question is, do patients have to be careful with hot water distorting the flexTAP?
Absolutely. Heat will distort it if you throw it in boiling water. And what we do is we try it in the mouth before we do anything and see how well it fits. A lot of times, and I would say 70–80% of the time, it can be fitted without putting in hot water. What we do is have 160-degree water, which is not boiling, but we only dip it in for 10 seconds and put it in the mouth. Generally, that will refit it very well, make it fit perfectly. And there's not a better fit than fit something directly in the mouth. I don't care what kind of digital made appliance there is. This will fit superbly.
Okay, wonderful. Next question. In what cases are you still recommending the DreamTap, or are you almost exclusively switching all patients to the flexTAP?
I think it depends on the dentist and his comfort level within. What I would do is just like we did. We start changing people over from the DreamTap to the flexTAP, and ask them, well, what do you like about it and how does it? I would say about 80 to 90% prefer the flexTAP, just like you saw those 2 patients, particularly the lady that had such a severe apnea. In my own case, everybody's case, a lot of cases, I don't have to pull the jaw as far forward. It doesn't lock my mouth in one position. I have room for the tongue. So that's why this thing was designed. We still have excellent results with the DreamTap, and patients can hook and unhook it, so that may not feel locked in. One thing about the thing I like about the flexTAP, it does have that post on it. And so both of the things are together, and so you can put it in your mouth very easily and bite down on it. So our older patients that are not as capable as putting an upper lower jaw appliance in the mouth, they have a very good, better results, and can manipulate this much better than the DreamTap.
Okay, great. 2 questions we're going to answer real quick. A couple people want to know what the lab fee is. It's $404 is the lab fee. The next question is the webinar available as a recording? Yes, it is. So you will get an email after this or on Monday, and that will have a link to the recording. Next question for you, Doc, is do you do boiling water on every delivery, or is it sufficiently fit as delivered? Then no boiling water chairside if it fits as necessary.
Well, you use the water and the hot water as necessary. So we always try it in the mouth before we adjusted it at all.
I also know not boiling water.
Not boiling water, very hot water, but not boiling.
Okay. And have you found a discrepancy between male and female preference in the Dream versus Flex?
Not really. Not really. I think it takes some time to get, when you show it to a patient, oh, I don't want something sticking out of my mouth, and how am I going to kiss my husband, or things like that. And so it's kind of fun. But as some people have said, this is a whole hell of a lot better than CPAP, and as somebody says, it feels like I'm going to bed with snuffleupagus at night. Once they get used to it, once they have, that goes away, and how they feel in the morning, particularly breathing through their nose all night, is a game changer.
Yeah, and the same doctor, I think she says specifically if the male is a heavy grinder or clencher, it seems like the metal in the Dream would hold up better, but the Flex seems a lot more comfortable.
If you look at a lot of the new studies or whatever, a lot of bruxing, a lot of movement of the jaw is due to sleep apnea. So if that's controlled, particularly your big males, you know, as I say, old fat men, you get them controlled, their bruxing is reduced. However, it's much more comfortable, and because it's almost acts like a spring to keep the upper and lower jaw apart, they can put their teeth together and it's even in the back, just like closing down. But that pressure to open back up tends to keep them from clenching and going side to side, and particularly keeping their tongue forward. That kind of goes away. So I'm not seeing as much issue with that. We've had some issues with the screw post in front. We've had those stretch out, and we've improved that. We've changed the manufacturing of that. And we've seen this being very rugged. With the DreamTap, if you had a big bruxer, because they couldn't close down the back, they had no posterior stops, then we had to add posterior stops, I bet, on 50% of those. So with the flexTAP, we don't have to do that. I mean, yeah, flexTAP, we don't have to do that.
Okay, great. Next question here. What about the patients that sleep in a prone position?
Oh, I mean, there's no problem. I mean, that post sticks out a little bit, and we see great results in any position that they're in. So I haven't had any complaints, or there's not any outcomes difference in whatever position you're sleeping in. That's one of the nice things you see. Even we can treat the severes if they're on their back with this device, because it can move out further than any other device. You can put it in your mouth, and we have patients moving it 1 to 2 millimeters beyond maximum protrusion and what I call passive protrusion. And we know that joints can go into a passive stretch, and you can do that with an oral appliance. We've got a study that shows that improves outcomes significantly the further out you go. But those are only for the incredibly severe patients that, and as I tell people, the only patients I've referred are what I call roadkill. And these are people that all have failed the CPAP. Virtually don't get patients that haven't been treated before, and we're seeing very good outcomes with that.
Okay, great. Are there any other, is there any best practices for daily hygiene with the flexTAP that you would recommend? This is coming from a doctor that's a longtime DreamTap user, but has delivered their first 2 flexTAPs.
There is some cleaners that we are putting in with that, and you can buy that. That seems to work well. We also just brush it with a toothbrush and do that. It maintains it pretty well at this point, what we see.
Okay, can the flexTAP mouth shield be compatible with other oral appliances?
No. There's a thing called Somnoseal, and Sleep Physician developed it. You can go online to find it. And she says you can use it with oral appliances. I haven't seen it. A lot of people will, if the mouth shield comes loose from the tap, a lot of people will spit it out or it'll come out. So I haven't seen, that was one of the reasons that we have gone to the flexTAP, because we can attach the mouth shield to it. The good question is, does breathing through your nose improve outcomes? If you look at a very recent study where they taped a number of different appliances, taped the mouth shut, and improved the outcomes and the reduction of AHI significantly. And I certainly have that. It was done by Danny Eckert and from Harvard, and it was out of a dentist office that did it. And I think it's a real seminal study saying all appliances need to look at mouth breathing, because virtually a lot of them, maybe most of them, people are still breathing through their mouth sometime at night.
Okay. Can the vertical height be altered if it is too tall?
What happens is, and that the reason is at 45 degrees angle is typically you have to move the jaw further forward to get more room for the tongue, or move it back for less room for the tongue. So if you don't need the vertical, generally you don't need the same amount of protrusion. So we're looking at the position of the tongue more than vertical or vertical space. So and that's why we have a mouth shield, so it prevents mouth breathing. So vertical is adjusted by the movement forward. We do have in the MyTap various shims to actually open it up more and not shut it down, because it can be too little vertical opening. And we may have the shims. We're in the process of looking at improving the flexTAP with some ideas, and may have the shims in that to increase vertical. I've never seen, or not never seen, I need more vertical. In the study that was done by Hookema, all of those were at, I think, over 13 millimeters, every one of them. In the Army study was 497 patients, and our laboratory actually did it. Nobody open up to at 11 millimeters incisively, and the outcomes are better than anything ever published. So, and that's some studies that I can send you. I've got, thousands of studies and a lot on the tap. In fact, you can go online, and I think there's 70 to 80 studies now, and they're independent of me. I've never done a study. If you look at all the other studies, Somnomed or Prosomnus, it's done by people that have big time conflicts of interest in it. And so one of the things I'm really proud of is that all of these studies are independent of me and independent of my company.
Thank you. What do you use to heat the water?
I have a microwave. So it's in the office, and I just turn on a little bit and have a cup of coffee, a coffee cup, and just dip it in it. So it's pretty simple.
Perfect. Nice and easy.
Yeah, and some people have these teapots that they heat up. I mean, this is not rocket science. I've treated people in hotel rooms, and we've done it at conventions and things like that, and with the MyTap, and it's incredibly easy.
Very good. Where do you see failures in the material, and can it be repaired?
You can always add thermocryl. That's an amazing material, and it's polycaprolactone, melts at 160 degrees, made by Union Carbide, and there's a guy named that was called Mr. Tone. It's polycaprolactone called Tone. And I asked him, well, could I buy 5 pounds of it? He said, well, no, that's our size for just sending out people to try. We actually usually sell it by a 55-gallon drum or train car load. It's used as it's a organic polymer, and it's used like so it can like garbage bags. It'll deteriorate in a landfill. It is a tough polymer. We can irradiate it and make it maintain its shape. It's incredibly tough. So we can easily add a little thermocryl to that to repair it. We've done some things mechanically so that we don't see the breakage that we initially saw. And so we don't see a lot of repairs to it.
Okay. When are you recommending posterior tabs and stops on the Flex?
We haven't done that. I think we've done it once or twice to increase vertical on some people that have really large tongues. And so we've done it that way. The design of it is it does hold the jaws apart, but because of flexibility of the post, and it's made out of nylon, people can close, and they close evenly on the back part of the 2 appliances. So we haven't, that's one of the nice things, we haven't had to use posterior stops. That's why this jaw joint can move, and the jaw can move up and down, right and left, keeps the joint lubricated and is more comfortable, and it takes way less time for the jaws to get back in the morning to a normal bite. So for me, and I wear one every night, I at this point don't have to use the AM aligner, because I can get my jaw joint back in normal alignment very quickly. And I do have my jaw protruded, even though I think I'm a skinny dude, and I've got 4 bicuspid extraction and all the issues with too small a oral cavity, too small a box.
Okay. Do you feel that this appliance will be better for upper airway resistant patients?
Yes. Skinny women's. This is something I started talking about 30 years ago. It came from John Rimmer's. High upper airway resistance generally are with people that have a low arousal threshold, or they are hyperarousal and they wake up quickly. Putting the mouth shield on it, making them breathe through their nose, calms them down. So does the nitric oxide. And so nasal breathing is parasympathetic breathing. We've seen superb results. These people are very tired. They don't desaturate, but they show all the other signs of sleep apnea. These are the ones that are underdiagnosed and are not diagnosed by the sleep docs with a PSG. Generally, you don't see a great AHI, but you see all the other symptomatology. And if you look, if you have a esophageal monitor, you can see the negative esophageal pressure. And we've seen this with high upper airway resistance. Their negative esophageal pressure is generally -8, and it can go to -35 to 40. So you got significant pressure on the chest and hemodynamics of the heart. So it's a real issue. So yes, it works. That's a long answer.
Great. This next question is regarding the warranty. So we know that the warranty is for 3 years. but what are you finding is the typical lifetime of the Flex? Or what would you recommend as far as patient education is, that if the patient took care of it, can it last for 5+ years?
Oh, I hope not, because we can sell more, but that's just, I'd say that facetiously. This is based on the MyTap, and we had some original MyTaps, and actually before that, some ones that were prototypes. I've seen some MyTaps that are 7 and 8 years old still working, but that's why we say at least 3 years, and generally we see them lasting 3 years, and they come back, and if they're still working, we don't replace them. And so the flexTAP hadn't been out that long. MyTaps have, and they last a long time. We say for the MyTap a year, flexTAP for 3 years. And the nice thing about both MyTap, flexTAP is you change dentistry, and in 3 years, a lot of people have new restoration, whatever. Do they have to make a new appliance? Not at all. You take it back, you heat up a little water, it fits again. And so we see that as a real advantage. So we see less changes of appliance because of that.
Okay, next question. Is there a higher incident for tooth movement with the flexTAP?
We don't see it. And one of the things that, and it goes back 30 years, that we saw hard devices that didn't snap on the teeth open up posterior contacts on the lower. And that's why we went to something that covered the height of the tooth and went into the undercuts. And so we're seeing, and then 20 years ago, we started adding some way to get morning aligners. That's why we have morning aligners, and we coined that term. What I'm seeing with our new morning aligners with flexTAP, I have not seen the movement at all. In fact, the last 4 or 5 years, unless they don't use the morning liner, we just don't see tooth movement. Anything else?
Yep, sorry there, I was muted here myself. One more question here. What would you recommend for mouth breathers that have trouble breathing through their nose?
First of all, make sure there's not a mechanical issue. And the way I do that is NT taught me years ago to use a collar maneuver, which is, can you breathe through that nostril? Can you breathe through that nostril? A lot of times they can't breathe through the nose at night because they're breathing through the mouth, and because of this blowing off the CO2 and changing the pH, you're going to get swelling of the lining of the nose. There's some ways once we start doing that, and one of the things they can do is put the mouth shield in and use it for an hour before they go to sleep, and they'll see that they can breathe through the nose. One of the biggest things that they come back and say, oh my gosh, I can breathe through my nose for the first time. It's wide open, and that's why they feel so much better in the morning. If they have a mechanical problem, then refer them to an ENT to take a look at it.
Okay, great. Yeah, that's it for questions here. We're going to jump back in here if we can as well. Yep, there we go. So yeah, there's no more questions, but a couple more comments that I just want to echo. Actually, quite a few comments. Really, all kudos to you, Dr. Thornton. This is such a great webinar, great presentation. Thank you, Dr. Thornton. Thank you, Dr. Thornton. I'm just going to echo those. We really, really appreciate you taking the time to do this. This has been fantastic. And thank you to the engagement of the participants. The questions were fantastic. This has been a really, really great hour. We will follow up. If you guys have any questions, please email Jenny, call us here at Great Lakes. We can connect with Dr. Thornton, whatever anybody needs, please reach out.
They can actually contact, I mean, I love to do this. I mean,
Great.
you know, as I say, I'm 78 years old and still going, and this is what fires me up and teaching people, and I love to do this. So, you know, call me and I'll certainly get back to you. You know, I want everybody to be successful with it.
That's great. And it looks like all of our contact information is on all of your screens now. So please email us, call us. We're happy to answer any follow-up questions. And once again, Dr. Thornton, we really, really appreciate your time today.
Thank you so much. And thank you, Kelly, as well.
Thank you, Kelly.
Put your head in here, Kelly.
Thank you, Kelly. Fantastic job.
The feminine pulchritude. There we go.
The extra millennial in the background.
Yeah.
Yes.
All right.
All right, I think that's it. Dr. Thornton, do you have anything else before we go for the day?
I don't. Thank you.
Okay. All right. Thank you all. Thank you, everybody, for
Thanks,
taking the
guys.
time to join us today. Take care.
Bye.
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 Good job.
Can I go over?
Wait, they're gonna end it. You're still on. See?